Welcome. Thank you for joining us for today's Sight and Sound Bites webinar. I'm Carrie Fogel. I'm the Senior Director of Development and Foundation Relations here at the Eye Foundation. So I'll be moderating our webinar today with Dr. Zevallos. As you know, we host these webinars every month in different topics related to vision loss, hearing loss, head and neck cancer, sinus, allergy, balance disorders, and conditions of the voice. Quick reminder for any new guests that we won't use the chat function, during the webinar. We will ask that you submit any questions for Dr. Zevallos to the Q&A box, which you'll find at the bottom of your Zoom screen. I will hold all the questions till the end, and then I'll moderate the Q&A portion of today's talk with him following his presentation. And as always, there will be a video of today's discussion available on our Eye Foundation website. So again, thanks for joining us. It's my honor to introduce Dr. Zevallos, José P. Zevallos. He is the Eugene N. Myers Professor and Chair of the Department of Otolaryngology and Head and Neck Surgery here at the University of Pittsburgh. He's also the Interim Deputy Director over at the UPMC Hillman Cancer Center. Dr. Zevallos became chairman of this department in August 2022. Previously, he was the division chief of head and neck surgery at the José B. Kimbrough and the José B. Kimbrough Endowed Professor of Head and Neck Surgery at Wash U in St. Louis. Dr. Zevallos' clinical interests include the management of head and neck squamous cell carcinoma, salivary gland tumors, thyroid and parathyroid conditions, and benign tumors of the head and neck. He also has a special interest in transoral robotic surgery for HPV-positive oropharyngeal squamous cell carcinoma. He has also a strong interest in head and neck cancer epidemiology and population sciences. Dr. Zevallos has published over 120 peer-reviewed research articles and is a highly sought-after speaker at national and international conferences on head and neck cancer. He is a member of the International Head and Neck Cancer Epidemiology Consortium, the American Head and Neck Society, the American Thyroid Association, American Association of Clinical Endocrinologists, and the American Academy of Otolaryngology Head and Neck Surgery, and the Triological Society. He is a fellow of the American College of Surgeons and sits on the editorial boards of Oral Oncology and Cancer Medicine, and is an associate editor of Head and Neck. Dr. Zevallos is also the founder and chair of the board of molecular diagnostics startup company Droplet Biosciences based out of Cambridge, Massachusetts. Droplet Biosciences was developed Lymph Detect Head and Neck, which is a CLIA test that identifies head and neck cancer recurrence with unprecedented immediacy and sensitivity. He continues to be actively engaged in entrepreneurship and the development of responsible academic and industry collaborations across otolaryngology. So we're thrilled to have a discussion today about using head and neck cancer for using liquid biopsy and for diagnosis and prediction of outcomes. And it's going to be a great discussion. Please submit your questions throughout the program at any time, and we'll make sure that we get them answered. Thank you. Dr. Zevallos?
Great. Thank you, Carrie, very much for the introduction. It's great to be here and to share some time discussing some of the research that we do in our lab and how we think it can impact the future of head and neck cancer treatment. So it's an exciting field, liquid biopsy, which I hope to share with you today. First of all, my disclosures, the only one that's relevant to this talk is the first one, Droplet Biosciences, that Carrie mentioned. I'm the founder of a company that's based in Cambridge that is doing work commercially in this space. I don't work with them under science directly, but I founded a company about 4 years ago. So as Carrie mentioned, I'm the chair of this department. It really is the honor of my professional life to be chair at University of Pittsburgh. As some of you may know, the University of Pittsburgh is really one of the founding centers for modern head and neck surgery. It began with Dr. Gene Myers, who you see pictured here, who was our first chair. Dr. Johnson, also a head and neck surgeon, was our second chair. And I'm fortunate to be the third chair of this great department. We now have 60 full-time faculty. We've recruited about 14 clinical faculty since I arrived here 3 years ago. We have a very, very strong department that's kind of marries both really clinical excellence with research excellence in a way that's unique. As of January of this year, I was the interim deputy director of our cancer center. I am now the permanent deputy director of our cancer center under John Bird, who is our new director, an exceptional leader, and really a new and exciting era for Hillman Cancer Center. And I'm fortunate to be part of the leadership team. We have a very strong multidisciplinary head and neck cancer team. Head and neck cancer is only treated effectively with a multidisciplinary approach, and it really does take a team like this to make sure our patients get optimal care, surgery, radiation oncology, medical oncology, pathology, etc. This is really what makes outcomes great. And we are on the forefront of research in many different aspects at Hillman Cancer Center, and very proud to be one of the largest and one of the leading groups in head and neck cancer, both clinical care and research. So today we'll talk about circulating DNA, liquid biopsy, and its effect on head and neck cancer outcomes and diagnosis. So first, I want to start with what is liquid biopsy? What is circulating tumor DNA? So, in our bodies, our cells are constantly producing, and as our cells replicate, we produce cell-free DNA, which is freely floating DNA in blood that's shed naturally by all normal cells. Circulating tumor DNA is cell-free DNA that comes from cancer. And these are tumor-derived fragments of cell-free DNA in circulation that are not associated with tumor cells. So they are the product of necrosis, apoptosis, or exosomal release, which means as the cells die or as they send out signals from cell to cell, it produces these free-floating DNA fragments, which are typically characterized by being 160 to 180 base pairs in length. And when we talk about ctDNA, it's used most often for something called measuring molecular residual disease. And that is that when a patient has a cancer treated, we can measure ctDNA in blood or in plasma after their curative surgery, whether it be surgery or radiation therapy, as a marker of what's left behind residually. And of course, given that we're measuring minute amounts of ctDNA within an ocean essentially of cell-free DNA, it requires ultra-sensitive assays such as PCR assays or next generation sequencing assays to find these fragments of DNA. And the idea is that we can use these fragments of DNA to predict a patient's risk of recurrence, or even in the setting of somebody who is at risk of cancer but doesn't have cancer yet, you could use it in theory to find the cancer earlier, and therefore, do imaging studies and treat it as early as possible. There are two ways of doing this currently. One is at least in patients who have cancer already diagnosed. One's a tumor-informed approach, and one's a tumor-naive approach. In the tumor-informed approach, what we do is we find a sample of the primary tumor. We do an analysis of the tumor, find the mutations in that cancer, and use those mutations to go find those same mutations in blood. In the tumor-naive approach, we don't need the primary tumor. The mutations are commonly found in these kinds of cancer, and we can essentially look for them in blood as a marker of molecular residual disease. So both approaches work for different cancers, and I'll talk about both of those approaches today. So how do we use ctDNA in cancer care? So there are multiple places within the cancer continuum where we can use these measures in blood. One is to measure response to neoadjuvant therapy. So, for example, a patient who's going to get surgery for head and neck cancer, we may give them immunotherapy up front first. And as we're preparing for surgery, we can measure whether they've had a response to the immunotherapy as we're preparing to do the surgical resection by measuring not just what the tumor looks like on imaging after immunotherapy, but what it looks like in terms of residual ctDNA. After surgery, we could use it to find minimal residual disease, or is there tumor DNA left in the blood after the tumor has been operated on? And that can give us clues as to whether the patient needs radiation therapy, chemotherapy postoperatively, for example. After treatment, we can use it to detect recurrences. So a patient currently with head and neck cancer will be seen every 3 months in my office. We do a thorough exam. We look in their throat. We look we palpate their neck, and we look for disease. And we oftentimes get imaging as well. But there's a chance that this could be used in theory to find the risk of recurrence before it manifests on a CT scan or on a physical exam. And if you were to find it in theory, you can then do more imaging to try to find it and treat it as early as possible. And then if a patient were to recur, it could also be used for treatment response monitoring. So across all of cancer treatment, there's a lot of theoretical places where ctDNA could be used for a variety of different indications that can either predict risk of cancer recurrence or identify it as early as possible. So if one looks at the data for how ctDNA has been incorporated into practice, colon cancer and lung cancer are the two places where it's really become almost standard of care at this point. And here's an example of a very important paper that was published a couple of years ago in the New England Journal of Medicine, where they looked at the use of ctDNA for guiding adjuvant therapy after surgery for stage 2 colon cancer. So as you can see on the left, patients were either selected to go into a group where they all had surgery, but some of them had treatment adjuvantly, so radiation therapy or chemotherapy afterwards, based on the standard clinical pathologic features. So currently, you look at the pathology, and based on the risk of the pathology, you give them radiation or you don't. In the other group, they didn't account for pathology. They based the decision for radiation therapy only on ctDNA. Was it molecularly positive or not? And importantly, what they found was that there was no difference, as you can see in the top here on the right, there was no difference in recurrence-free survival between the patients that were treated based on ctDNA compared to the patients that were treated based on standard management with pathology. However, and really importantly, half of the patients, or double the patients who were treated with standard of care, received chemotherapy, whereas only half of them received chemotherapy compared to that group in the ctDNA group, which means that if you made decisions based on ctDNA, you were able to avoid chemotherapy in many more patients rather than the way it was given as standard of care. And remember, the outcomes were exactly the same. So what this showed us is that using ctDNA allowed us to more precisely give therapy to patients and have them avoid chemotherapy when they didn't need it. So this was a landmark study called the Dynamic Study, which has really set the stage for the use of ctDNA to make adjuvant therapy decisions in colon cancer. And it's become, as I mentioned, an important part of the treatment paradigm for colon cancer as a result of this study and others. There's also been significant work done in lung cancer. This is a study done back in 2017, which has now flourished and led to the use of this similar assays in lung cancer. This was led by Otto Chowdhury, who's a close collaborator of mine. We were both previously at WashU. And what they did was they looked at early detection of molecular residual disease in lung cancer using ctDNA. And what they did after treatment with chemotherapy and radiation therapy, they checked the blood at 4 months post-treatment and were able to determine whether or not this predicted recurrence or not. As you can see here, they found that the patients where there was no ctDNA detected had significantly improved outcomes compared to those where it was detected. So these are Kaplan-Meier curves. The red is patients where ctDNA was detected. And you can see that their survival was significantly worse in patients who had ctDNA at that 4 month time point. Patients who had no ctDNA at the 4 month time point had significantly improved outcomes, as you can see the black line on the top, where most of the patients went on to survive their cancer by that 36-month time point. So, lung cancer, colon cancer, these have become important parts of treatment, and the technology continues to evolve to really incorporate them into workflows for patients with these cancers. So the question is, what about head and neck cancer? Oftentimes, because head and neck cancer is relatively rare compared to lung and colon cancer, we are often not at the forefront of industries as they start thinking about assays like this. But there has been work done specific to head and neck cancer in the use of ctDNA. The best example is for patients with HPV associated oropharynx cancer. And this is an early study from 2020 by Bisham Chair and Gaurav Gupta at UNC Chapel Hill. And what they did was they measured HPV DNA in patients with HPV-associated oropharynx cancer. And in this particular study, what they did was they looked at 115 patients who had treatment for HPV oropharynx cancer, of which there were 15 recurrences, and they found that the negative predictive value of HPV DNA in blood was 100%, and the positive predictive value was 94%, which tells you that this test was very, very good at identifying those patients who were at highest risk of recurrence after they completed their treatment. Importantly, as you can see on the left here in this time to recurrence plot, uh, HPV DNA positivity, the median was 3.9 months. So it was positive about 4 months prior to detection of the cancer clinically. And in one patient, they found the HPV in their blood 14 months before the case actually manifested as a clinical recurrence. So the challenge with this technology and with many others is that you can have patients where you have a molecular positivity. So you have, in this case, HPV DNA in blood up to 14 months before the patient has a detectable cancer. And the question is, what do we do in that time point? Do we increase the surveillance? Do we look for, do we incorporate more exams or more imaging to find it? One could imagine it would cause significant anxiety to a patient if you have a molecular positive test, but nothing to do about it because you can't yet see the cancer. So this is where these technologies really have to be incorporated into how we treat our patients to ensure that they have a meaningful impact on their survival. So importantly, in this study, and actually every study that's been done so far in head and neck cancer, even though we're able to find the cancer in theory earlier, it doesn't actually, no study has yet shown an improvement in overall survival. Because right now, finding it in blood through a molecular signal where you can't really do anything about it doesn't necessarily improve survival. So that's a big question mark as to how we incorporate this best into our clinics. So there was a lot of excitement given the data that we showed. I just showed previously in the Beecham-Chera paper about how we can use HPV DNA for the management of this disease with negative predictive value of 100%, positive predictive value of 94%. But all the studies that had been done up until this study, which was published earlier this year, were all retrospective, which means that they looked at patients that were treated in the past. They used blood samples retrospectively, and they were able to find these results. This was the first prospective study using HPV DNA in patients treated with head and neck cancer. And what they found was that the results were not quite as good as had been shown previously. So suddenly, the sensitivity is 73%. And as you can see here, if you look at the plots on the top right there, or 115 patients, again, 15 recurrences, 40% were early true positives, which means the test worked quite well. In 33% of patients, these were confirmatory true positives, which means that the patient was getting a PET scan or imaging regardless. They saw a tumor on the PET scan, and at the same time, they also found a ctDNA. So the value of that test is less clear. In 27% of patients, these were false negatives, which means that the patient went on to have a recurrence, but the test missed it. In 20%, they were false positives, which means the patient had HPV DNA, but went on to not have a recurrence. So you can see here that especially the false negative and false positive rate were significantly higher than what had been published previously. And it does call into question the utility of an assay like this in our practice. So I think studies like this have really changed the way we think about the use of HPV DNA in HPV positive oropharynx cancer. And I think a lot of our colleagues around the country, even though there is a commercially available test, are questioning now how do we best use it for our patients when you have a 73% sensitivity. There's also been work done to see if we can mimic the study I showed you on colon cancer, where you can test whether or not the DNA could be used for adjuvant therapy decision making. So there was a study done at Memorial Sloan Kettering. This has not been published yet, but was presented at the 2024 meeting in Phoenix, which is our big head and neck meeting. And what they did was they asked whether or not patients could have received radiation therapy, not based on pathology, but based on whether they were positive for HPV DNA after surgery. And frankly, this test really failed pretty catastrophically. They had to close it early because 25% of the patients who were negative on HPV DNA went on to have a gross recurrence by 6 months. And basically, what this showed us is that this test is not ready for us to be using to make adjuvant therapy decisions. And this has been kind of a cautionary tale for incorporating an HPV DNA test like this for making decisions about radiation and chemotherapy postoperatively. And the conclusion was that this HPV test failed to provide an early signal of the disease progression in patients who were treated surgically. And in many ways, it makes sense. If a patient has surgery, you've removed the vast majority of the tumor, and therefore the signal in blood is going to be significantly less. And we think that the sensitivity of the test was not adequate enough to find those minute amounts of DNA that were predictive of recurrence, and therefore the test failed and the trial was closed early. So, if you look at the literature, there are multiple studies, most of them retrospective, showing the potential utility of HPV DNA for oropharynx cancer. It's been proposed that it could be used for early detection of HPV oropharynx cancer, evaluation of a neck mass in an adult, determining HPV status in patients where it's indeterminate, response to induction treatments before surgery, adjunct to imaging, all kinds of different things have been tested. And for the most part, the signal is there that there is potential for the use of this and that it seems to be effective in some cases, clearly not in the postoperative setting. But for many indications, it seems like it may potentially be an adjunct for our decision making. However, what has not been shown yet is whether HPV DNA can actually save or extend lives. Also, what's not been shown is whether it's cost effective or not. So this test is now commercially available, and otolaryngologists and oncologists order it all the time in the community. But the reality is that no data have yet shown that this test leads to an improvement in overall survival, and there has not been a head-to-head comparison between using this test and the routine surveillance that we've always done for this disease, showing that it's cost effective. So all that to say, there's a lot more work to be done before we start really thinking about how we incorporate HPV DNA into our treatment. So, what are the current limitations of ctDNA for head and neck cancer? As I mentioned already, the prospective data have been largely underwhelming. There are no large prospective studies that compare HPV DNA to routine imaging or clinical examination. There's no demonstrated survival advantage to earlier molecular detection. So, finding it early in blood doesn't imply that your survival will be better. There's no available next generation sequencing based assay for variant detection, which means right now HPV is an easy target because we know it doesn't belong there, and we can use it as a surrogate for tumor DNA. For HPV negative cancers, you don't have HPV to measure, and we don't have an ability yet to measure mutations from those specific cancers. And therefore, as I mentioned here, the indications for HPV negative cancer have been less. I also mentioned that there's the recent data on adjuvant therapy decision making has been underwhelming. So all that to say, even for the indication that's been here with us the longest in head and neck cancer, which is HPV DNA, there is a long way to go yet as we think about how we can use liquid biopsy in head and neck cancer. So I want to shift a little bit to some of the work that my lab has been doing to try to answer these questions. And specifically, the questions that I want to address are these last two here. That the recent data on adjuvant therapy decision making is underwhelming, and then HPV negative cancer, we have no tests available for those two. So when I look at the challenges and really where we can have the most impact in how liquid biopsy could be used, I think it really comes down to incorporating liquid biopsy into the curative pathway, which means not just using it to find recurrences, but finding ways of bringing it into our treatment planning before a patient has recurrence. And also, the other question I really wanted to tackle was the HPV negative question, because although HPV positive cancers are critically important, survival for HPV positive cancer is about 90%, whereas survival for HPV negative cancer remains about 50%. So I think we have opportunities for more precision treatments and improvement in survival in HPV negative cancer. So we asked a fairly simple question. Given the challenges I mentioned in the Memorial Sloan Kettering data and others, could we improve the sensitivity of adjuvant therapy decision making by sampling more proximally than blood? That means instead of measuring the blood and drawing blood from the arm when we're dealing with a head and neck cancer, is there a way of us going directly to the source and measuring biofluids in the head and neck after surgery that can give us more sensitivity as we start thinking about decisions for treatment? And we're of course not the first ones to think of this. People have been looking at saliva for head and neck cancer for a long time with really mixed results. There's been all kinds of studies looking at pleural fluid, urine, stool, etc. And the reason why there's an interest in looking beyond blood is because plasma has inherent limitations. As I mentioned at the beginning of the talk, it requires an ultra-sensitive assay because we have very little ctDNA in circulation. It doesn't provide for localization of the disease. So if you find a signal, it doesn't tell you that the signal is coming from the neck or the tongue or the lung. It just tells you the signal there. And we think that proximal biofluids may be more enriched for tumor DNA and therefore provide more ability to find and characterize the risk of local regional recurrence. So, as I mentioned, people have looked at all kinds of fluids, and we decided about 4 years ago in my lab at WashU to look in this fluid, and this is the surgical drain fluid. So, as a surgeon, this is something I deal with on a weekly basis. We do operations, we place surgical drains. But nobody had, prior to our work, nobody had explored whether or not this fluid, which is part of routine surgery, includes ctDNA, or whether it could be used to prognosticate risk of recurrence and make decisions about adjuvant therapy. But if you think about it, it does make a lot of sense. Number one, it's the earliest possible landmark time point after surgery. So if you want to find residual disease, you can use this fluid, which has basically been bathing the tumor, to look for residual cancer and may be, in theory, better than blood. It has the potential for prognostication, but also for adjuvant therapy decision making. As I mentioned before, blood was not successful at making decisions about adjuvant therapy, but given that this fluid is coming directly from the tumor bed, we thought, well, maybe it has more ability to find patients at risk of recurrence, and we can use it for those important decisions. It localizes the risk of recurrence, so we know if the fluid is positive in the left neck, that the recurrence risk is in the left neck rather than the right neck. And we think it's adaptable across multiple solid tumor types. So surgical drains are used very commonly in cancers across the body, and it's really a platform, a novel fluid platform for measuring residual cancer that had not been explored. So really, over the last 4 years, we've been focused on exploring that. So this is our first paper that was published in 2023 where we looked at patients with HPV oropharynx cancer, 120 patients, and we collected this fluid from their neck because they had all had neck dissections in addition to the tumor being removed, and we compared it to blood drawn at the same time. And we ran a PCR-based assay for HPV DNA, similar to what I just presented, and we compared it as well to a next generation sequencing, so a kind of a higher technology for sequencing variants in addition to the PCR. And this is work led by Noah Erland, who's a MD PhD student at WashU. Ricardo Ramirez was my resident, and Otto Chowdhury, longtime collaborator now at Mayo Clinic. And we found that the amount of DNA in the neck in this fluid correlated very well with how the risk of the patient with respect to their pathology. So you can see here that patients that were positive for nodal disease, which means they had positive lymph nodes, had higher amounts of HPV DNA in their drain fluid than patients without it. We found that patients that had extension of their lymph nodes, so their capsule had been violated by the cancer, they had slightly higher HPV DNA than those that were just node positive alone. And we also found that if we looked retrospectively and said, how were these patients treated? What was the decision at the tumor board about whether they should receive radiation, no radiation, or radiation and chemotherapy? We found a really nice dose-dependent relationship between whether the patient was recommended for the most advanced treatment compared to radiation alone versus no radiation and their HBV DNA level. So we said, oh, well, it seems like we're onto something here. And then we asked in A, as you can see here, that whether or not the presence of HBV DNA was prognostic of survival. And we found that, in fact, it was significantly associated with survival. So the patients that had HBV DNA in their fluid measured 24 hours postoperatively had a highest risk of recurrence compared to those that were negative. And we also looked not just at HBV DNA, but we looked at the mutations in these cancers, and we found that the mutations lined up very well with what we would expect to see with HPV associated cancer. So it gave us confidence that in fact we're dealing with ctDNA rather than just HPV DNA alone. So this was our first study showing the proof of principle that measuring HPV DNA or ctDNA in surgical drain fluid was in fact prognostic. And this was a commentary that was written about our paper back in 2024. And what they did was they put our finding, our discovery, in the context of HPV DNA for head and neck cancer in general. And I think what they did well is that they included the use of this surgical drain fluid as an additional potential adjunct marker for determining whether a patient deserves radiation or chemotherapy postoperatively. It certainly doesn't replace blood, and it certainly doesn't replace pathology, but it's one more data point that you can use to provide precision care for patients with this disease. And that's really what how we envision this as well. So then what about HPV negative head and neck cancer? HPV negative head and neck cancer is the most common cancer of the head and neck. It's also the deadliest cancer of the head and neck. So we did a similar study that was just published last week, also in Clinical Cancer Research, where we looked at 120 patients with HPV negative cancer in two different cohorts, one at WashU, one at UPMC, and we found very similar findings where at one day, so 24 hours postoperatively, the presence of tumor DNA in the surgical drain was significantly associated with survival. These were two independent cohorts and showing very similar results. We then looked at more specific subsets of head and HPV negative head and neck cancer, and we found that, as you can see in A, that our signal in ctDNA and surgical drain fluid or lymph was significantly more prognostic than blood. In B, you can see that the patients who benefited the most, you saw the biggest difference between the positives and the negatives were the intermediate risk patients. And these are patients where oftentimes there's debate and dilemma about what to give them postoperatively in our tumor boards. So I think the indication is perfect for patients where you have these decisions to make. And then in C, we compared the sensitivity and specificity of our test, which is the top row here, to the typical things that we use to make decisions about patients postoperatively. And we found that our test outperformed the majority of the traditional pathologic features that we use to make decisions about radiation and chemotherapy postoperatively. So we found that they were both prognostic, and we showed here that we think it could be used in the future for decision making in a prospective fashion. We then looked at other different kinds of patients with HPV negative cancer. We looked at low risk patients, and our test seemed to work quite well in low risk patients. So those that were N0, so had no positive lymph nodes. These are very low risk patients, but some do recur. And oftentimes these patients get surgery alone and no radiation therapy. And we found that in these patients in particular, we had a separation between those that were positive and those that were negative. And of course, these are very small numbers, so it wasn't quite significant. But I think there's the potential to use it in this patient population. And then similarly, in patients that were node positive but had no breakthrough of their capsule, we also found very similar results. So where do we see this technology going? We think that a clinical trial in the future could be designed to escalate therapy for patients that are positive in the surgical drain fluid, which means that patient, based on their pathology, they would get radiation alone, but if they happen to be positive in the fluid, we would give them chemoradiation. So that's a trial that we envision that would be safe for patients because it wouldn't be taking away therapy, it would be adding therapies for those patients that were deemed highest risk based on the signal in their fluid. So this is one design that we're thinking through for the future But there's centers across the country now that are collaborating with us to design trials and to collect more and more fluid. It's been exciting, obviously, because nobody had ever done this work before. We were the first to really explore the fluid and the potential for this fluid. So we spent a lot of the last 4 years understanding the potential of using this fluid that was, up until now considered waste fluid, and how we could leverage it to improve the care of our patients. We received a big grant from the NIH recently called a UO1 to explore this in more detail. So I'm very, very happy to receive this grant given the challenges with NIH that we've experienced recently. And what we'll be doing is really focusing on the pre-analytical side of this, so optimizing conditions to make sure that this fluid is ready to be used for these sophisticated assays and both for ctDNA and for other work that we'll be doing here at Pitt. And where I see this going in the future is uniquely in head and neck cancer. Given that we have this discovery of using this fluid, we now have three different bioanalytes that could be used immediately after surgery to predict risk of recurrence and also to localize it. So in head and neck cancer, if you have a tongue cancer operation, we have saliva to test postoperatively. We have surgical drain fluid as a marker of the nodal burden, and we have blood as a marker of the distal burden. So uniquely in this disease, we have what I'm calling a liquid TNM, tumor nodal metastasis, that we can use in addition to pathology postoperatively to figure out where the radiation field should go and how much chemotherapy a patient needs based on not just measuring in blood, not just pathology, but incorporating all of these different bioanalytes. And we published this work as a kind of a thought piece in 2025 recently in head and neck to show this potential. So, in addition to ctDNA, one of the unique things about this fluid that we've been exploring is the immune cell composition. So, of course, this is primarily lymphatic fluid. And so the immune cells that we find appear to be similar to the immune cells that you see in the primary tumor, which allows us to use this potentially as a window into the tumor microenvironment. And in the era of immunotherapy, there's a lot of interest in classifying the immune microenvironment. And we think that our fluid has potential because the immune cells that we're measuring in the drain fluid are coming from the lymphatics that were coming essentially from the primary tumor. So we're just beginning to explore this now. We have several smaller grants that we've received to do this, and we're now proposing a much larger grant to do a full characterization of the immune composition in this fluid. We're also working with Sunny Bao's group at Pitt. She's an immunologist to incorporate our cells as a source of autologous tumor reactive T cells. So in these organoid models, so she's created these incredible models for tumor where she can grow not just cells from a cancer in a dish, but she can grow an organoid. So essentially, all the different characteristics of a tumor, she can grow them in a dish from a patient. We can then take immune cells from our fluid and grow them with the organoid, and hopefully, in theory, demonstrate that the cells that we harvest are able to kill tumor cells. And you can imagine if you have a system like that that's working, you can test different types of therapies within those models that can allow for more precision for the actual patient care. So this is down the road, but I think it's a very promising area that we've been working with her lab on, and Josh Smith, who's one of our newest hires, head and neck surgeon, is working with her on developing these models further for head and neck cancer. So, in conclusion, ctDNA has potential as a marker of molecular residual disease across multiple cancer types. And as I mentioned, can go from diagnosis to treatment selection to treatment response and surveillance. Head and neck cancer is far behind other cancer types. And I think the use of this test should be done with caution, given that the prospective data have been underwhelming, and for especially for HPV DNA. We think that local regional MRD detection and postoperative detection remain significant challenges, and we think that using proximal biofluids like the one I described from the surgical drain fluid is a promising avenue as an adjunct for helping, specifically in patients in the immediate postoperative setting. And then, as I mentioned, SDF, surgical drain fluid, has the potential to serve as a marker of molecular residual disease, both HPV positive and HPV negative cancer, as well as a window into the tumor microenvironment and immune cells, not just for head and neck cancer, but for cancers across the human body. We have cohorts that we're building in lung cancer, bladder cancer, and breast cancer across the country with cancer centers, and hopefully we'll have more data to share in the coming years. So thank you very much for your attention. It's been a pleasure to give this webinar and very happy to answer any questions. Thank you.
Thank you so much. And thank you for putting the photos of your family at the end.
Sure.
I always enjoy seeing them. Um, well, again, that was a really wonderful talk. We feel very lucky that you spent the hour giving us that talk. I know you give it all over the country, all over the world. And so here in Pittsburgh and our reach of the guests today, we're very happy to hear all of that. So let's get to some questions. Please feel free to submit any additional questions, while we're starting off. And we'll try to get everybody out of here by 1 o'clock so everyone can have lunch. So one not silly question, but just kind of a basic question. What is in surgical drain fluid? What is surgical
Yeah.
drain fluid?
Yeah, great question, and we're working diligently to figure out exactly that. But it's a combination of lymphatic fluid. So we've based on the protein analysis, we think the majority of it is lymphatic fluid, with lymphatic channels kind of parallel the circulation system in our bodies, and it's a major source of cancer spread. So we think it's primarily lymphatic fluid, blood, interstitial fluid, which is a fluid that lives between our cells normally, and as well as tumor. So that's what we see as the composition. But like I said before, nobody had really ever asked what is this fluid. So for us, it's been a lot of exploring to really trying to figure out this composition over the last several years.
Okay, that's interesting. So as this is not yet kind of the standard of care,
Mhm.
and someone's thinking about, okay, what happens to my surgical drain fluid? How
Yeah.
long can you store surgical drain fluid, that would potentially be viable for any sort of postoperative prediction?
Yeah, so great question. So to be clear, yeah, there is, we Droplet has a test now approved for head and neck cancer, but it's not the standard of care yet, certainly. So right now, the way it's collected is not designed to measure DNA. So we have shown that we can collect it and immediately process it with a buffer that preserves DNA. And that could be used and preserved, for weeks if we incorporate this buffer right away. But right now, there's in under most circumstances, there's really no utility to the fluid, given the way it's processed and stored now. So really, unless you incorporate it or quickly put it into this solution, it won't really be useful at all. And remember, for the last 100 years of surgery, this fluid has been thrown in the trash, right? And so the bulbs and the tubing that's designed for evacuating wound fluid, was not designed with ctDNA in mind, certainly. And so that's something that is a challenge that we're up against is that um, we're not, the tools that we're using weren't designed for measuring molecular residual disease.
And that does seem like quite a large challenge, but not an insurmountable one, hopefully.
Mhm.
So how long after you collect the surgical drain fluid and you perform the test what's a typical timeline for when you would inform, the treatment paradigm as they move forward and make
Yeah,
the
so
decision?
right. So the goal is to return a result in 2 weeks because patients after surgery they start radiation around 6 weeks postoperatively. So our goal would be to have the result back well before treatment decisions are made about the need for adjuvant therapy. And we think that that's a unique advantage of this fluid because, as I mentioned before, drawing blood immediately postoperatively as a marker of residual cancer, the assays are not sensitive enough given the low amount of DNA. But the fluid we have found, I didn't mention this, but there's 130 times more cell circulating tumor DNA in the fluid than you find in blood. for a patient. So the fact that the signal is there means that there's more potential to use it prognostically.
Great, thank you. Is there such a thing as a typical recurrence time frame for head and neck cancer? Is it 2 years down the road? Is it 5, 10 years down the road? And how sensitive would this test be for that?
Yeah, so most great question. So the majority of cancers of the head and neck recur within 2 years. Actually, 90% or more recur within 1 year, and almost all of them recur within 2 years. So, when we looked at our test, we looked at 2 year survival. So we were able to, remarkably, I think, measure something immediately postoperatively and be able to predict recurrence that happened up to a year later. So cancers of the head and neck rarely recur after 2 years.
Okay,
After 5 years, we ultimately consider them new cancers.
okay, wonderful, thank you. Um, you mentioned the difference in HPV positive versus HPV negative cancers and why HPV negative cancers are so much more deadly than HPV positive. Can you speak to that a little bit?
Yeah, it's these are, even though they occur in the same location, they're biologically very, very different cancers. So the mutations that drive the tumors in HPV negative cancer aren't present in HPV positive cancer. And we know that the cancers respond very, very differently to radiation and chemotherapy, and that's the main driver of the differences in outcome. We think more and more that this has to do with the immune response to the cancer. If you look at an HPV positive cancer, there's a lot more immune cell infiltration compared to an HPV negative cancer, and we think that that's what drives many of the differences with respect to outcomes and survival. So, very, very different cancers driven by very, very different mechanisms, which results in very different outcomes.
So, wondering if some of our guests maybe would like to know kind of what could create, HPV positive head and neck
Mhm.
cancers. We understand kind of where that comes from. That comes from the dormant virus that people get earlier in their lives. What kinds of things cause HPV negative head and neck cancers?
Yeah, so typically, HPV negative cancers are caused by tobacco and alcohol use. The majority of the cancers we see of the mouth, throat, voice box are all caused by tobacco and alcohol use. There is a group of patients who are not virally driven, so HPV negative, that aren't smokers. And it's an area of interest epidemiologically that we're trying to figure out why some patients get cancers even though they don't have risk factors. We've seen an uptick in patients with oral tongue cancer, and we think it may have to do with host immunity or other factors in the mouth. But really, to now, there's no clear evidence as to why we're seeing an uptick in patients who are oral tongue cancer in particular, who are non-smokers and not driven by HPV. It's an area of active research that many of us are focused on without really clear answers right now.
Hmm. Thank you.
There seems to be a correlation with autoimmune conditions. So we think that the immune response to these lesions is maybe what's driving some of these findings.
And would that be an inflammatory type of response that
Yeah,
you're kind of considering? Okay.
yeah, exactly. But the biology of this really hasn't been determined to date. If you look at these cancers under a microscope, if you look at them, the mutations, they look very similar to the smoking-related ones. They
Hmm.
don't look different, which is really interesting, and I think lots of work is being done now at the population level to see what those trends are, but also on the molecular level to see what underlies these tumors.
Interesting. Thank you. So we'll keep working on that
Yeah.
answer. Excuse me. But so now that you're the deputy director over at the Hillman Cancer Center, and you see kind of everything that's going on over there, are you tapped into kind of are people working in liquid biopsy over there already, or is anyone using surgical drain fluid? Kind of what does this technology look like as you consider everything that's going on in cancer research here in.
Yeah, it's a good question. There is work in liquid biopsy being done, I know, in breast cancer, in colon cancer, a lot more work to do. With respect to surgical drain fluid, nobody, we're really the first people to do this work, and I think I'm hopeful that we can start doing other cancer types. I've been talking to colleagues at Hillman, doing pancreatic cancer surgery, for example. We started collecting with some colleagues there. And we think it's just another potential area of investigation that may lead to more precision in the way we treat our patients postoperatively. Um, so I'm hopeful that it will expand beyond head and neck cancer. But right now, I think, we're probably one of the very few groups in the whole country, really in the whole world, looking at this fluid type right now. So hopefully it catches on and more people start investigating it.
Thank you. One of our guests has said, congratulations. We have interest from UCL in London in the UK. Do you plan to expand your trial?
We hope we our trial. So the Droplet is sponsoring the trial and beginning to do that work and talking to working with other cancer centers around the country to see if we could start that trial in HPV negative head and neck cancer. Ideally, yes, we would expand the trial both nationally and internationally. I think there was a question around the harmonic scalpel or
So yes, that might
okay,
have been a spelling error that I didn't anticipate. So a harmonic
okay.
scalpel, is that okay?
Yeah, yeah. So a harmonic scalpel is just a tool that we use in surgery to when we cut and cauterize tissue. I don't know. I love the harmonic scalpel. But it has nothing to do with surgical drain fluid, at least from my perspective. It may be that different tools will lead to different amounts of fluid. I guess maybe the heart of the question. But I think what one of the things that we did early on when we had this crazy idea of using this fluid was we looked at 5 or 6 different surgeons with different techniques and found whether or not the amount of HPV DNA was consistent across all the different surgeons, and it seemed to work the same exact way. So I think irrespective of technique or instruments that you use, I think the signal remains.
Thank you. One final question before we get going. And this relates kind of less to the technology, but a little bit more about the state of HPV vaccination.
Yeah.
Many people don't come across, it's not in the news all that much. And if you don't have young children, maybe you aren't so familiar with the guidelines on HPV vaccination, where it
Hmm.
stands at the state and the federal, the national level of what is recommended. So
Right.
anything you would say regarding
Yeah.
that?
Yeah, sure. My other area of interest, as you mentioned, is epidemiology, and we've done a lot of work with vaccination. The current recommendations right now are that everybody, men and women, boys and girls, up to age 26, the recommendation is for vaccination. The debate has been in patients between 26 and 45 years of age. And right now, the recommendation is in patients aged 26 to 45 years of age, that you do it under shared decision making with your physician. And what that means is that if you have other reasons to be higher risk, for example, if you're immunosuppressed, if you have other conditions that may put you at higher risk for HPV oropharynx cancer, they may allow you to have the vaccination up to age 45. But universally, it's recommended to age 26. And I think I would, I would highly recommend everybody who's eligible to get the vaccine because we know it prevents HPV oral infection, which is the precursor to HPV oropharynx cancer. And HPV oropharynx cancer, incidentally, is now the most common HPV-associated malignancy in the U.S. So it's no longer cervical cancer. And the problem is we don't have effective screening for this cancer because the cancer uh, goes asymptomatic for a long time before it's found. We're doing a study right now in the veteran population for young veterans, and we're assessing what percentage of people, when they come into the VA system, have been vaccinated. And we found that the rates are quite low, even for patients that were eligible during their youth. So we worry that in a system like the VA, the risk of oropharynx cancer will be higher than the civilian population, and that's an area of interest of mine that we're exploring right now is looking at that age group of young adults who have not yet been vaccinated and what that means for future rates of oropharynx cancer. But I think given everything in the news and the changes with the federal government, I'm afraid that a lot of the research in this area will diminish. But I'm hopeful that people will still continue to vaccinate at higher rates so that we can prevent this cancer.
Thank you. I think that's ultimately what everyone here on this call can agree on. But this was a really fascinating talk of wonderful new technology, and we're really proud that you brought it to Pittsburgh to grow it. This is something that came out of your lab in St. Louis, and you brought it here, and we're excited to kind of be one of the piloting sites whenever it does get into trials.
Yeah.
So, thank you for sharing with us. Thank you all who are on the call. And please, if you have any further questions, you may submit them to the email that the invitation came from, and we'll make sure to get those over to Dr. Zevallos. And please share the video of this recording widely with anyone you think might be interested. So I'll let everyone get back to their day. Thank you all. Thank you, Dr. Zevallos.
Thank you very much, Carrie. Thank you all for your attention. Have a great day.